Hello everyone, I'm Dr. Mrunmay and I will be conducting today's Odonto Odyssey session. So this is our initiative wherein we bring to you clear concepts and clear aligners. This is regarding our cases which we have completed. So you will have an idea of the kind of cases we have, the kind of cases we have completed, how we go about it, and what are the kind of treatments case options that you should start with. What is it that you should choose if you are a beginner when it comes to aligners, and how you can gain confidence with clear aligners if you are a new practitioner. And if you already have experience, then you get to just see different cases and how they are treated, how we plan them, and we go ahead with it. So I will just give a brief introduction regarding this. So, so the introduction with it is, I am Dr. Mrunmay and I am a planner with Odonto. And we plan the treatment for you right from the part wherein we receive the cases. We will tell you what treatment is possible with aligners for these cases, how we can progress, what outcome can be expected out of it, what are the treatment options which are available, whether the patient will be extraction, non-extraction, and we will lead you through it. In case you have any doubts regarding it, then you can always get back to us with your queries and we proceed from there. So you can either send in your scans or you can send in your impressions for the model, 3D models to be made. We will plan it, and Odonto does everything right from helping you choose your cases so that you gain confidence in your practice with aligners and how you progress with it, along with the treatment planning, which we do. You will also be assisted with the fabrication, the delivery, treatment progression as the treatment progresses from the initial stages to any intermediate stage and beyond. Completion of the treatment, the kind of retention which is required, the retainer types also which are required. If you have queries regarding those will be addressed. In case of proximal reduction, which is IPR, which is required more often in aligner therapy, if that is required, how do you do IPR? Because if you do it perfectly, then you definitely derive results which are according to the plan, and you encounter lesser complications as you progress. In case of attachments, how the attachments are to be placed, we have videos for the same. They are very clear in terms of how to place the attachments, kind of materials that are to be used for attachment placement. And if you still have any queries beyond that, then we help out with those. In terms of once you join the program for the Odonto Provider Program, in that case, you are also helped out by a salesperson who will get in touch with you and help you out with any other logistical details that will be required. So today's what we do is that we give you an introduction as to what Odonto is. So we are a company which provides aligners, and they're specifically designed for dentists. So even general dentists with the help of orthodontists. So all of us on the panel are orthodontists who provide the treatment plan for you and help you out with your treatments. So we provide only orthodontists for the same to help you in your practice to straighten teeth and correct any malocclusion that you might encounter. And it is an alternative to traditional braces, which comprises of either metal or your aesthetic braces. So this is another treatment modality we help you out with. So we will proceed with the kind of cases which are treated by Odonto and what it is that you will be receiving in turn. So this is what you receive as a setup. So once you send in your scan, we make a 3D model out of it, and based on that you receive a video. You will have the photos which will be showing you pre as well as the treatment progresses and the final outcome for the same. So this will be a video which you receive, And the video basically takes you through the treatment from stage 1 sequentially. As the treatment progresses in multiple views, it will show you. So this is a video basically which gives you an idea of what the treatment is. The number of sets also you can gauge from it, because every movement that you see taking place, that is an indication of every step with the aligners which is there and how the treatment progresses. So in this you can see what the initial patient profile is. You can see there is a lot of spacing which is present. There is an diastema which is there, which is pretty massive diastema which is there, and how you would want to close the space. Now, as a case, this is one of the good cases to start with, because this is a simple space closure, because as we can see, the posterior occlusion is very stable. It is already in class 1. So our main concern is to retract the teeth and close the spaces, which is done sequentially. So we do not require a lot of posterior movement in such cases. What we are concerned with is closing the anterior spaces and achieving a good overjet as well as an overbite. Now, in these cases, you must have seen that in the video also, we can see that as you start, there are attachments also which are required. Now, these attachments have to be placed on specific teeth. They are either to help hold the aligner in place, as though we don't have any movement occurring in the posterior teeth, but we have these attachments there which are helping us to hold the aligner on the teeth, because we don't have any braces or any brackets over there. When we have the anterior attachments, they are to help with certain movements. So they can be attachments which are helping control the tooth movement, to help us move in a certain direction, to prevent certain unwanted movements from taking place. So in that respect, we require these attachments to be placed on the teeth, and they will be given to you right at the start. If they are there through the treatment, any changes, then those will be mentioned in the treatment notes that you receive from us. So in those terms, this is a good case. When you have a diastema case, something that clinically you should evaluate when you're sending is if there is a high frenal attachment. In some cases, when there is a high frenal attachment, you will require a frenectomy to be performed. So if that is required, you need to clinically evaluate that, inform the, when you fill the form, inform us about it, and then we can advise you as to what stage that frenectomy is to be carried out, and so we have a better retention as terms of avoiding a relapse in terms of the diastema. We can move on to the next case. So this is a similar case that we have in terms of the previous one that we saw. The main difference over here is this large open bite which is present. So though we have a stable posterior occlusion, we have an anterior open bite. Now, anterior open bite cases are very good cases to start off with. The reason being that there are certain occlusions which are favorable for aligner treatment, and an anterior open bite is one of them. If it is a dental anterior open bite, definitely it can be corrected with aligners. And this comes in around more up to your 25 to 30 sets. We can have correction for these malocclusions. In this, we have to first ensure that we are closing all the spaces. And as we close the spaces, it also helps to close the anterior open bite. In this case, we can see that as the teeth have been retracted, we are also closing the bite anteriorly and achieving a good overjet and an overbite. Now, in these cases, the other is that on the setup that you receive, you might receive an overcorrected simulation. Now, this is something that we have to program into the treatment plan that we send you, which is why that you will have a deep bite at the end. And you might wonder, like, I don't want such a deep bite, but why has so much correction taken place? This is just something that we program into your treatment plan to ensure that the movement takes place up to the desired amount. And we just program this overcorrection to ensure that in cases wherein we have a large malocclusion, we are able to close it in a more favorable manner. So this is one of the more favorable cases for correction of the malocclusion in terms of using aligners. If you have a crossbite case, as we can see out here, there's a single tooth crossbite which is present. This will also be a mild case. It is a good case to start with, and you will have good results with this, and it will also help you to gain confidence as you move ahead. There is minor crowding which is seen in this case. There is a blocked central incisor and an anteriorly blocked, buccally blocked lower central incisor. Now, these teeth can be corrected with your aligners. It is a predictable movement that we see. And for that, this will again be in your mild category. So it will take you less than 20-25 sets to receive correction completely. Some small amount of proximal reduction will be required in these cases to relieve these contacts so that we are able to have smooth movement of the teeth as we are progressing through. In case of blocked out incisors, even if it's just a single incisor, but when the bite is overlapping, then we program something which is like a bite ramp, which helps to disocclude the teeth posteriorly so that as the teeth are crossing over, we have correction of the bite. We do not have a lot of occlusal interferences, so which helps. So there will be bite ramps also, which will be programmed into the correction, into your treatment plan for the correction. And this is how we can have a look. Some amount of intrusion is required. And then we have the anterior overjet, which is again well established. If you have posterior crossbites, those can go into your moderate categories. Anterior crossbites, which are limited to either 1 or 2 teeth, they are very easily corrected and can work out in few sets, up to 20 in a mild category. So these are the bite ramps that I mentioned previously. So though they appear as attachments, as a practitioner, you do not need to place them. They come programmed into the aligner, and that helps to open up the bite and allow for your bite to jump. So such cases also can be done very easily with your aligners, and you receive a good occlusion provided the patient wears it, because patient compliance is one of the keys to achieving a good result when it comes to aligner treatment. Now, this is a crowding case. It would not be a mild case. This is not a case one would start off with as an initial case, because we have crowding. Yes, the teeth are locked in. They are also tipped. They are not absolutely straight. So what happens when we have multiplanar movements is that we need to isolate those movements. We need to first create space for the teeth to come into line. Then we need to upright them, and then we need to have the final correction. So these movements need to be isolated, and we cannot have all the movements programmed together, because then it becomes very confusing in terms of we can program those, but then the outcome is not favorable. The reason being that the plastic will deform, and the plastic will not bring about the kind of movement that we are looking to achieve. So a case like this would go into your moderate category, which will require more than 25 sets for correction. And this will require sequential movement. And for that, we need to place attachments also. Sometimes all attachments cannot be placed right at the start. We need to place few attachments at the first stage, and later on, few attachments can come into the picture. We can also notice out here that we have laterals which are not exactly peg laterals. The one on the left can be said as to be a peg lateral. These teeth may require some amount of composite buildup for aesthetic purposes. If the space is not adequate, it cannot be balanced. So that as the Bolton's discrepancy, in which the tooth size and the space available in the arch, there is a mismatch between the two, and we need to balance it out. In case when there is space is present, a case of spacing, in such cases, what can happen is that we might close all your lower spaces and we might require buildup of the laterals at the end of treatment. We do not do this buildup in the middle of the treatment because that would then have us asking to reboot the case, in which what happens is you have to send in a new scan or set of impressions in case there is any change in the tooth structure, which is why we will leave the adequate space for you, and then you can progress to the end of the treatment, at which point you can do either a veneer or a composite buildup, which is there. You can proceed with that to have a more aesthetic result in terms of your anterior. In cases of crowding, what we would have required is proximal reduction, but we avoid that to a certain extent because the tooth size is already small. It's not too bad aesthetically, which is why we can leave them as they are and not try to change the shape of it. It is again at the discretion of the treating dentist as well as the patient expectations, because sometimes patients come with very specific expectations in terms that they want only anteriors corrected and they're not concerned about how the posterior bite is. Sometimes the patient will come to you with a very specific concern that the posterior bite is bothering the patient. In those terms, you have to accordingly plan and do it. Also, in severe crowding cases, we cannot have teeth at the back as well as teeth in the front all moving at the same time, because then there is no hold for the teeth. We need anchorage for the teeth in terms that when we are moving the teeth in the front, the posterior teeth are going to be your anchor, wherein they will be holding the unit, and we can bring about movement in the front teeth and we can proceed. And sometimes when we are having movement only in the back teeth, then we have to hold the front teeth as an anchor unit because we have to balance this out. If we try to rush ourselves into moving the teeth, posterior teeth as well as the anterior teeth together, what happens is that there is no anchorage, there is no support, good firm support that we receive. And in such a case, what will be that your aligner is not going to fit the patient. There can be bowing that takes place, or there can be teeth which do not track, in terms that one tooth gets left behind and the rest of the teeth are falling in place, which is why again you will have to pause the treatment and you will have to restart in terms of taking a new scan and sending a fresh model for it. So, which is why we do not want to rush into the process that we want to reduce the number of sets, because sometimes we have to be a little patient and allow movements posteriorly and movements anteriorly to happen in isolation, and not just try to run after reducing the number of sets, to ensure that we receive a good favorable result in terms of relieving the crowding, closing the spaces. We have to isolate those movements. So have a look at this video. So as you see that we have to first expand in the posterior region, make space anteriorly to open up the bite, and then we start aligning the teeth. Now, if we try to combine all these movements together, the problems which I mentioned previously in terms of loss of tracking of movement or the arch shape not following the plan, that can take place, which is why we have to sequentially expand posteriorly, hold the anterior teeth. So you will also have to explain to the patient that they might not immediately see results, though what we try to do is that as we are moving teeth at the back, we try to correct small mild rotations or uprighting of teeth, but we don't bring about major movements, and the patient will have to show some amount of patience in terms of achieving the anterior results. So that can happen, though we try to achieve anterior results first because that also leads to patient satisfaction. Otherwise, patients, there can be fatigue, and if they don't see results anteriorly, they're not too satisfied with the treatment progress. So this is one way. And yes, so this is basically how you would go about it. The initial cases which were there are the mild cases, the spacing, as well as the open bite case which was shown. So mild cases are very good to start with. Sometimes the minimal amount of correction might require just around 10 sets. Sometimes it can go up to 20 sets. So anything till 20 or 22 sets, we categorize it as a mild malocclusion, and accordingly. Now, these cases are good to treat. You will get favorable results. It also helps you to gain confidence in using aligners, and that helps you to progress to more moderate cases and even complex cases in terms of using those with a hybrid approach, wherein if it's extremely complex, like deep bites are there or so, then you can also balance them out with your conventional braces. But we try to keep it up to your moderate category, wherein we can try to treat the entire malocclusion using aligners alone. These cases will also help you in terms that if you have good results, then your patient referrals also increase because there's greater chances of patient satisfaction. And any minor hitches that you encounter, they are easily corrected, and then you can progress with it, which helps as a practitioner for you to also offer a treatment option wherein you are confident about how it is going, and sometimes you will yourself be able to manage it at your end, and you will be able to progress, because this becomes in that you have to communicate with the patient. That helps you to do that, communicate better with your patient. If there are any questions regarding these cases that I have shown today, or any other cases that you might have and you have queries regarding those, we can look into any queries that you might have regarding patient selection, case selection, kind of cases which can be done very easily. This is just giving you an overview of how the cases at Odonto are. Now, these are specific cases for the week that we are in. So we keep compiling more cases as the weeks progress, and we have a gallery which you can, for which we can share the link and you can have a look at, which will help you also realize as to what scope of treatment is possible, what it is that you can achieve, and you can show the patient that this is what has been treated with these aligners and you will achieve a result, and this is what you can expect out of treatment. This is one of the options that you have. We can share the link for it. And though this gives you just an overview of it, we have the Odonto Provider Program, in which we will in depth explain everything about aligners, right from the basics of the aligners, and then we can proceed with it. Though that is the Aligner Provider Program, for which we will provide the link for it, and you can progress through that and have a look at how to go about it. For now, if there are any questions, then I will address those. So we have shared the link for the Aligner Provider Program. You can click on it and join the program, wherein you will be given with, you will have your salesperson who will assist you with the cases. You will be in touch with them. They will help you with the logistics of it in terms of your scans which have to be done, the specific scans, if there are impressions which you're taking and you want to have those impressions sent to us and having the plan done. In case you encounter any other queries or you have any other problems along the way, then we can always help you out with that through the salesperson. And all this will be possible once you join the Aligner Provider Program. In that, we will also have multiple sessions in which you learn about the aligners, how the biomechanics of aligners are, understand how they work, what is the entire scope of aligners, and any other questions that you might have, you can ask those right away and can help you out with those. We've also shared the link for the cases which have been done with Odonto aligners. These are cases which we have done them personally, and orthodontists are the ones who do these cases, plan these cases for you, and also any troubleshooting which is required during the treatment at any stage. You will always be having orthodontists and not technicians who will be helping you out. So with clinical scenarios as well as any other query that you might come across, we will be the ones always helping you out. If you have any questions regarding the cases, you can ask those. If you have questions regarding cases which have not been shown today and you want to still know anything else, you can ask those questions either in the chat or you can unmute yourself and speak. That should also be fine. Are there any questions that anyone would want to ask? Any doubts that you might have regarding, then we can always help out with it right away. Okay, so I have a question here. How much of posterior expansion, corrections, rotations, and premolars can be expected? Up to 2 mm of expansion is what we program into your aligners when we send the plan out to you. And in terms of expansion, if there are rotations, depending on the degree of rotation, we will categorize it as a mild, moderate, or a severe rotation. Up to 5 degrees is considered a mild rotation and can be done, corrected very easily with the help of attachments. If it is 10 degrees or so, we might require auxiliaries which come into the picture. Now, auxiliaries are that there will be an attachment on the tooth, as well as you might have to bond a button. All these will be provided to you. You might have to bond a button, run a few elastics, either buccally or lingually, and you will have to allow for correction of it. So we can have a higher degree of correction. The aligner alone will not correct it, but you will have auxiliaries in terms of buttons and elastics which are placed on the teeth, and you will have a greater degree of correction. Up to even 10 or 20 degrees of correction can be achieved. That goes into your moderate category because the tooth shape is such that we do not have a good fold on it, which is why we need to make use of buttons or any other modes. These can be aesthetic ones which can be provided to you, or the metal buttons can also be placed if they are posterior teeth. If they are even on your first premolars and you want derotation take place, then we can give one aesthetic buttons for the same, so that the patient has, even when smiling, the first premolar is visible, but the button will not be as prominent as a metal button which is placed. If your premolar rotations are approximately 90 degrees or so, it's derotated, or even 180 degree of rotations, then these are the kind of rotations which are not entirely possible with aligners alone. We can program those, but we do not give guarantee as to how they will track. Those come into the moderate to severe category rotations. And if the posterior bite is not affected in that, as in there are no high contacts which are there, then in such cases we do not carry out rotations of these derotations of these premolars. We leave them as they are. But if there are any heavy contacts which are there for the premolar, in that case we will relieve those contacts so that there won't be further wear off of the tooth, and we can prevent it from worsening. But corrections, then we do not bring about those corrections. I hope that answers your query regarding your premolars. If they are anterior teeth, then we can always have a higher number of correction, because the shape of the tooth is such that it has a surface wherein the aligner can go and hold better around it, and we can bring about correction. In those also, anything beyond 20 degrees, then we require the use of auxiliaries, and in terms of buttons and elastics, which will help us with it, help us with the rotation of the same. So that is how we proceed. Any other query that might have, or anyone else wishes to ask? Minimum set of aligners per case. This depends, it's multifactorial. It depends on the correction which the patient is looking for. If it is a mild case wherein there is only a diastema of say up to 1 mm which is present, or in that case, then minimum case set can be 10 sets that we can look at. And yes, you could receive the recording. We'll have to speak with Mansi in case it can be provided, so that you have an idea regarding the same. Minimum sets are also in terms of how much movement we program into every aligner. So what we do is we have a set standard of 0.2 millimeters per aligner in terms of linear movements. That will be either buccolingual, that's facial movements which are there. In case of rotations which are present, then it will be 2 degrees which is placed. So 2 degrees and 0.2 millimeters of movement is required, is programmed per aligner. So based on your clinical patient whom you have, you will have to accordingly factor in the number of sets which are required. In case of relapse cases, it can be around 10 sets which are required, but anything up to 20 cases, we again still count it as mild, and it goes into the minimum number. Now, that is what we program into the aligner, and you will have to accordingly calculate. That's how. Recording of this session, yes, I think it should be available. We can speak with Mansi, who's assisting me with the technical part, and we can give you the recording for the same. Cost per set. Now, in terms of the pricing which is there, we have categories. So mild, you will have a moderate, and you will have a severe category. In those, what we have is mild is up to 20 sets of aligners, and you will have a certain price range for that. Anything beyond that, up to 35 sets, you will have a price range. And if there is a severe case which is there, then in that case, your pricing will be on the higher side. We do not have a per aligner pricing which comes into the picture. We have it according to the category, and we do not have that. We also have your PETG aligners, and then we have something which is known as the Zendura aligner, which is a slightly more advanced material in terms of it has better adaptability to the teeth. And if you have moderate and severe malocclusion which is present, then it helps you to track the teeth better. So what can be done with those aligners is that when you have complex cases in terms of something like this, if you opt for Zendura, which definitely costs a little more than your PETG aligners, but it gives you a more predictable result because the material can perform better. After last aligner, for permanent retention, will we give additional aligner as retainer within the package? Yes, we do give the retainer, which is part of the package. Once the treatment is complete, you have to evaluate the case as to whether you want to go in for the retainer or whether you require any refinement. Now, a refinement is where if there is any mild rotation which has not tracked optimally, you want further correction for it, then do not request for the retainer, request for a refinement, wherein you will have to send a new scan, and we will make that fine correction for you, and then you can progress and go ahead with the retainer, which will be a clear retainer. In case it has been wherein you have closed a large diastema, in terms of the one that I showed in one of the previous cases, in such a case or the case before that, then these will require permanent retention as well as your clear retainer. So giving dual retention is always better, especially in cases with a large diastema or severe crowding. In such a case, what you can do is first bond your fixed retainer, opt for a fresh scan or for a new impression, and then we can always send you the retainer which is fabricated on top of it. Because if you first bond the fixed retainer and then ask for a retention, then what is going to happen is that retainer will not fit because your fixed bonded retainer will come in the way of it. So this is something you'll just have to factor in at the end of treatment, and you can have the aligner which will be the retainer which will be provided at the end of aligner treatment. I do not have a direct number for queries. We have a link for that, and you can drop your queries through the link shared to you. You can also join the aligner program, wherein you have any further queries. You will have a person who will be assisting you for the questions or any doubts that you have, and we can always progress through that. Any question that I have missed in this. Okay, no, I haven't. We have these, what is the Venesi Advanced Aligner program? Okay, so these we have them routinely. You can send your number and you can send in your number and we will get in touch with you regarding when the next program is being conducted, and you can sign up for it and you can attend those. Rotation also requires permanent retention. If there are anterior rotations which are there, depending on the severity of it, you can go in for a retainer. As orthodontists, we always advise that one should go in for dual retention. If that is not the case, then we can always use just your clear aligner, which will be which will have no attachments on it. It will be a plain retainer, plain clear aligner, which is to be used as a retainer. So premolar rotations, once corrected and once the bite is proper, the chances for relapse are much lower. The person who was asked regarding the aligner program, you can leave your contact number as well as your name is there. So you can just leave your contact number and you can get in touch with you regarding the same, and we will provide the details for the next round of the aligner program, which will be conducted. The program then will be more in depth, wherein we will explain the mechanics of it, how the movements take place, the kind of movements which are which go well together. We call them synergistic movements. Then we have antagonistic movements. So like if you're trying to close spaces and if you are trying to correct rotations, do they go well with each other? Or you need to first correct the rotations, then go in for closure of spaces. So all these concepts will be explained in detail, and that is how we progress with the aligner program, and those are explained in detail at that time. Okay, so yes, doctors, we can get in touch with you regarding the aligner program, and that is when you will also receive details regarding your pricing, which I was asked about previously. How those are, what are the categories, if there are anything regarding the Zendura, if you want to know, if you want to go in for the PEG, then those will be charged separately and you can ask for those. And there are categories even with the Zendura as well as your PEGs. So that information will be provided to you when you request for it and join in for the program. That is how it will be. Would anyone else want to ask any questions? Drop in their contact details to be, for the aligner program, then you can drop those over here. At the start, we have shared the link for the cases. First, permanent retention and then the intraoral scan. Yes. So once you are through the treatment, your aligner treatment, once you're satisfied with the results, that this is the end of it, then you will have to place your bonded retainer. You will have to fix that retainer, then take a fresh scan and ask for another a clear aligner retainer to be fabricated on top of the fresh one. Because if we try to fabricate send the aligner based on your first scan or impressions that you have sent to us, the bonded retainer which you will have placed, it's not part of your initial scans. This will come in the way and the aligner or the retainer is not going to fit on top of it, which is why you need to first bond your retainer once you're satisfied with the treatment outcome. After that, you will have to take a new scan or take new impression and send that across, on which we will fabricate the retainer and have it sent over to you. In case that any attachments or there, you'll have to remove all those attachments prior to placing the retainer, because the clear retainer does not have any attachment on it. The retainer will be on your smooth facial surfaces or your lingual surfaces, wherein there are no attachments placed. When you are going to send a new scan across, after you've placed a fixed bonded retainer, please remember to remove all the attachments which have been given to the patient. Remove all of them, use a burr and then clear it off, polish the teeth, and then send a fresh scan. That also helps, instead of it saves us time at our end to try and remove, or it avoids fit issues in case you send ask for retainers wherein the attachments are still present on the teeth. So if you remove the attachments at your end, it helps better than to ensure that the fit of the retainer is always better. That's how it will be. In case you are progressing directly without the fixed bonded retainer, then we send the retainers to you. They will not have any attachments. Before the retainer is given to the patient, they have to remove you will have to remove the attachments for the patient and then give them the retainer. Which burr is good for proximal stripping and which company to okay. So for proximal stripping, you will have different burrs are available. They are available either as a kit or they are available individually as per the size and depending on the kind of proximal reduction which is prescribed. So you have burrs for only breaking the contact between two teeth. So initial breakage of the contact, and then you run a second burr which will actually cut it. I would suggest that don't just be reliant on the burr to ensure that, I have run a burr of say 0.3 mm between two teeth and the burr is going smoothly. So that's the end of it. I don't need to do anything further. I would also just suggest that with a burr, also opt for a IPR gauge. So the gauge will have tiny thin leaves which are there, individual metal leaves. They are marked as per the size and you have to pass that between the surface wherein you have done the proximal reduction. So if you have done say 0.3 mm of proximal reduction, your IPR gauge has to go perfectly between the two teeth smoothly. There should be no tugging between that and you can accordingly have that. Now Strauss has good quality burrs. You can go in for those. They have either a kit or you can buy those burrs individually. You can always check with them in terms of how it works out. Those are better. You also need a lot of dimension of the burr. So dimensions of the burr are based on the proximal amount of proximal reduction that is required. So if you have a plan in hand wherein you have 0.3 mm program or you have 0.4 or 0.5 mm proximal reduction which is to be performed, then you have to use the corresponding burr for the same. So if you have 0.3 mm, then you use a 0.3 mm burr in that particular region. If you have 0.4, you use a 0.4 mm in that contact, and 0.5 you have to use it accordingly. So you can start off with those. You can also use the proximal strips which are available in particular dimensions. You have those proxa strips. You can use those to carry it out. So it will not be so you have a burr which comes specifically to break the contact. You can ask for that. It's a thin tapered burr which is available. It sometimes comes with a safety edge to it. So you can do that, use that to break the contact. Or if you are hesitant to use a burr right from the start for breaking the contact, then you can always use a proximal strip which is available to break the contact between two teeth, and then you proceed with the burr. So it avoids, and you just have to ensure that you're performing your proximal reduction perfectly, not to try and perform it at a slant or at an angle. So it always helps to break the contact either using a strip or a thin burr to break the contact, and you can just have it run vertically across. Like if the teeth are at an angle, then you have to ensure that there. But when we try to perform the what we do is we perform the proximal reduction only when we have good contacts. So if there is a case wherein the teeth are at an angle or so, then this is not where we can perform, because then you're just slicing off one tooth. You're not really breaking the region and trying to gain space. So this is what we would do, so which we can do that. So the company is Strauss, which is called. There are multiple others which are available, but this is one of the better companies which provides with the burrs, and you can invest in those. It always helps to invest in better quality proximal reduction, because once you perform it, you cannot undo it. So it is better to invest in burrs, which will help you to achieve the perfect amount of reduction and you don't go wrong with it. Because if you are done lesser proximal reduction, you can always add to it. But if you don't do it properly and you do it at an angle, or you reduce extra tooth material, then obviously, it throws your entire plan off, which is why that is how it would work out. You can use either the strips, the oscillating strips that are available, or you can use a burr. You can go in for either of those depending on your comfort level, which is to be done. After proximal stripping, is it necessary for fluoride application? Not always. If your patient is prone to caries lesions or already has a lot of multiple caries lesions, you can, in some cases, you can opt for a desensitizing toothpaste to be prescribed. Fluoride application is not 100% necessary thing. If the patient has good oral hygiene, then it's not absolutely necessary. Because if you go in for any topical fluoride application in terms which will take up space, it has bulk to it, then once you apply that, then the amount of proximal reduction which you have done, it negates it to a certain extent. So if you might have done 0.3, but your fluoride application, if it is slightly thicker or so and doesn't get removed completely, then what you're doing is you're occupying your space of proximal reduction that you have taken, you have performed. That's how. Polishing after proximal stripping, yes. So once you have done proximal reduction, which you have your two sharp contacts, which will be there. So these line angles which are made, like once you break the contact, which is there, you will have sharp line angles which form because you have run your burr or your strip straight through it. So you need to use a polishing strip and you run it across, but it will have to be wherein you are just smoothing down the contacts which are there. And after that, again, you need to use the gauge to ensure that you have done optimal amount of reduction. So yes, it is always better to polish after proximal stripping only in those sharp line angles so that you ensure, because teeth are never, all teeth naturally, they don't have very sharp lines which are there at the edges, at the proximal. They're always rounded.